cardiac rehabilitation is the same aerobic exercises and the same breathing exercise is what every physiotherapist thinks about. But let me tell you one thing. The aerobic exercise, whatever you're thinking, like walking, jogging, running, these can be actually contraindicated in some of the cases. And also the breathing exercise, whatever you're thinking, like the diaphragmatic breathing exercise, which you think might be useful to the patient, is actually contraindicated for many of the cardiac patients. Do you know that? If you don't know, then don't worry. Today, I have brought you a case, something like that, where I'll be telling you where the routine rehabilitation, routine cardiac rehabilitation, whatever you people are thinking that might be indicated for the patient is actually contraindicated. And I'll also talk about some exercises which we do not include in the cardiac rehabilitation but are very essential. Okay, right. I don't want to waste any time. I just want to quickly go into the case that I've brought for you. Let's just see the case first, okay? So I hope you people can see my screen, okay? Right. Yeah. Right. So going into the details of the case, we have a 62-year-old male patient who has undergone PTCA with stent placement, which is performed 3 days ago due to acute coronary syndrome. And the risk factors the patient had, that is the complications that the patient had previously or before the surgical procedure is hypertension, diabetes, previous myocardial infarction, that is MI, and coming to the post-operative or the post-procedure complications, the patient had the complications of AKI, which is acute kidney disease, chest pain, and heart failure symptoms. So before the surgery, the patient had hypertension, diabetes, and MI. After the surgery, the patient had AKI, chest pain, and heart failure symptoms. Okay. Before we further go into the treatment or the management in this condition, let's just know about few things. Okay, let's just know few terms in this case. First of all, the 62-year-old male patient has undergone one surgery, which is PTCA. Now, what is this PTCA? PTCA stands for percutaneous transluminal coronary angioplasty. See, when is this PTCA done first? Before knowing what about the procedure and everything about the PTCA, first let's just talk when is this PTCA done? Basically, PTCA is done in conditions where the heart, see, first of all, heart is an organ. We all know, we know that heart is an organ. But one more thing about heart is a muscle itself, okay? And heart has a function to supply blood all over the body. But heart being a muscle itself, every muscle in the body obviously requires some blood supply. In the same way, even though heart is supplying blood to all over the body, even the heart requires some blood supply. So obviously when it's requiring some blood supply, there will be some blood vessels for blood supply to the heart. And whenever these blood vessels are obstructed with some plague or atherosclerosis or thrombus or emboli, the blood supply to the heart gets declined. As you can see in the picture, you can see that there is some plaque formation in the blood vessel, as a result of which the blood that has to be passed from the blood vessel has got reduced. This reduction in the blood flow eventually lead to other conditions called as the myocardial infarction, which is nothing but your heart attack. So in order to prevent this heart attack or in order to treat this heart attack, we have certain procedures and one such procedure is PTCA. Okay. Now, whenever we are talking about surgical procedure, it's very essential to know if that surgical procedure is an invasive procedure or a minimally invasive procedure. See, I'm not telling it is a non-invasive. I'm using the term minimally invasive. Most of the students, what they do is they use this term, which is called as non-invasive surgery. Remember one thing, when you're talking about a surgery, there should be some incision done on the patient. You cannot like perform a surgery without performing an incision or without just having an incision or cut on the patient's body. So if you're doing a major cut or major incision, then you call it as invasive surgery. But if you're doing minimal cuts, okay, like small cuts, and then you're operating the patient, and it's called as minimally invasive surgery. So PTCA is a minimally invasive surgery. Here, you don't cut or you don't make larger cuts on the patient's body. Here, only you make a small incision, a small pinhole-like incision, and with that incision, you just perform the entire procedure. Okay, that is quite basics or introduction about the PTCA. Now going into the procedure of PTCA. Okay, so in order to perform PTCA, we select two incision sites. What are these two incision sites? We either choose the femoral artery or we choose the radial artery. So based on the artery that you are choosing, the site or the name of the site changes. You either call it a radial approach or a femoral approach based on the artery you are choosing. And the most common route that we usually choose in order to perform PTCA is the femoral approach. Okay, radial is also done, but most commonly and most conveniently, femoral approach is done. So I'll just show you the routes. Okay, so here the one that I'm circling is the radial approach, and the approach is performed from your elbow area. And the femoral approach, as you can see the circle, it starts or it is done at your groin area. Okay, now you've understood that there are two different incisional sites and we usually select one site from this. Okay, we have selected the site also. We have selected the femoral site. Now what shall we do? Basically, we make a small hole first in the femoral artery or in the groin area rather. We make a small hole and through this hole we send a guide wire. Listen carefully, we are sending a guide wire. Okay, as the name itself says, it's a guide wire, it's guiding something. Now, what is this guide wire guiding? This guide wire actually guides a catheter. Okay, now once you insert the guide wire into the femoral artery, along the guide wire, you send a catheter. Okay, now this catheter is sent to your coronary arteries. It is extended a little into your coronary artery. Okay, right. Till now, I hope you all have understood what is happening. Okay, now before treating the area of obstruction or before treating the area of block, we should know where the blocks are, right? So let's put this angioplasty aside for some time. Let's talk about angiography. Angiography is a procedure wherein you try to find out where these blocks are. Now the procedure is same. You make a small hole. You either take the femoral approach or the radial approach. Make a small hole. Send a guide wire along with which you send a catheter. And once the catheter reaches the coronary arteries, through the catheter, what you do is you release some dye. Okay. Remember this word. This dye is really important to further understand our case. So I'm stressing so much. Remember the word dye. You send this dye into the coronary arteries, and this special dye, what it will do is it will show you wherever the blocks are present. Now, once your blocks are sorted, you know where the blocks are present. What do? You'll send something called as a balloon. As you can see in the picture, there's something called a balloon. On the right side, you can see the balloon over there. Okay. Initially, what we'll do is we completely send a uninflated balloon into the coronary artery to the area of obstruction. Once it reaches the area of obstruction, what you do is you inflate the balloon. I hope you're understanding. This is the area of clot. Let's just say this is the area of clot. I will send a balloon inside the artery. Okay. After sending it to the area of block, I'll inflate the balloon. Okay. After inflating the balloon, I will remove the balloon outside the coronary artery and the artery will stay stable and the clot, whatever is there or the debris, whatever is there at that area will be eliminated. Okay, this is one method. And here in our patient's case, we have done a PTCA procedure with stent. Now, what is this stent? Remember, it is stent, not stunt, not the stunt that we do on bikes. Okay, it is stent. Okay, so stent is this metal mesh. I hope you can see in the picture. Stent is a metal mesh. Now, what you do? The entire procedure is same. Okay. In the first procedure, you have sent a balloon, you have inflated it, taken out the balloon. In the stent procedure, what you do? Around the balloon, you wrap a stent. Okay. And you send the balloon into the area of obstruction. Once it reaches the area of obstruction, the balloon, whatever is there, will be inflated. Okay. The balloon will be inflated. And after inflation, you will take out the balloon, but the stent will remain there intact. Now, the benefit of this is there will be no chance for the artery to prolapse again. Okay, that's one thing. So, PTCA can be done with stenting and without stenting. Okay, based on the requirement, we choose it. Okay, so yeah, if the case, like in the case that we're discussing, we have chosen a stent method. We have placed a stent to the patient. So now PTCA is clear for us. Now let's just talk about each and every complication that the patient is having. Now, we have some post-operative complications in the patient. We have three post-operative complications. Now, what are these complications? The first complication is acute kidney injury. The patient had acute kidney injury. Now, how can a patient with PTCA have acute kidney injury? That's my question. But before answering that question, I have one more question. What is acute kidney injury? Because it makes more sense to understand what acute kidney injury is before knowing about the relation between PTCA and AKI. Now, acute kidney injury is also called as acute kidney disease. Okay, initially it was called as acute kidney disease. Now everyone is calling it as acute kidney injury. Now, what actually happens in acute kidney injury is there will be sudden reduction in the function of the kidneys, and this sudden reduction is reversible. Okay, it is reversible. One benefit that we have is it is reversible. It's not unreversible. Okay, it is reversible. But now let's just talk about the next question. Okay, now we understood what AKI is. Now, what is the relation between PTCA and AKI? Now, now what actually happens is in some patients, I'm not talking about all the patients, in certain set of patients, okay, who undergo PTCA, they have this complication of AKI. Now, who are these certain set of people that we are talking here? These certain set of people are, if let's just say a person is already having some kidney problem. Okay, these people are more prone for acute kidney injury after PTCA, or if the patient is having diabetes. Again, this patient is more prone for AKI after PTCA, or if the patient is having heart failure. Again, patient is more prone for AKI post PTCA. Now, how is this actually happening? Why is a diabetic patient or a patient who is already having a kidney problem or a heart failure patient is having this AKI post PTCA? Let's just talk about all these three scenarios. Okay. Number one, talking about the first scenario, which is a patient who already has kidney problem. Let's just say a patient is already having this kidney problem. Okay. Now you have done PTCA. Now the thing with the PTCA is, I've told you as part of angiography, where in order to rule out where the clot is, we are just sending a dye. Is what I told you. In angiography, we are releasing some dye into the coronary artery. This dye has one nature. And what is this nature? It is nephrotoxic. It has a nephrotoxic property. Because of this nephrotoxic property, it will damage your kidneys. Okay. Let's just say a person is already having a kidney problem. Okay, a person who already is having a kidney problem, already suffering with a kidney problem, and you have given something which will increase the kidney problem. That is nothing but a dye. You have given a dye which is actually increasing the kidney problem. So obviously the patient will be undergoing, or the patient will have this complication of AKI. That's our scenario number one. The second scenario is diabetes. How is a diabetic patient who is having post-operative complications is actually having AKI? Okay. In diabetes, what actually happens is, see, diabetes is a condition where there will be increased blood glucose levels in the blood vessels or in the blood. Okay, right? Now, because of this, see, in patients, see, I'm talking about a set of diabetic patients, and these set of diabetic patients should have this criteria, which is they should be having persistently increased blood sugar. In the patients who have persistently increased blood sugar, what actually happens is the blood vessels become thick and weak. I'm using two terms, thick and weak. If you like properly observe, these two terms, thick and weak, are totally contrary words. Okay, they do not have any interlink between each other. Anything that is thick cannot be weak. If that makes any sense for you, anything that is thick cannot be weak. For example, let's just say there is a pencil. If you want to break one pencil, you can break one pencil very easily. But if you have to break bunch of pencils together, that will be tough. So anything that is thick cannot be broken down easily, but it is not at all true in case of the blood vessels. So in the blood vessels, what happens as part of diabetes, if a patient is having diabetes, first of all, the blood vessels will become thick because of the deposition of the increased blood sugars. Once it becomes thick, the basic thing what happens is, number one, the permeability of the blood vessel, whatever is there, gets decreased. Okay, because of this decreased permeability, whatever the components are present in the blood, say some proteins or structures, these all just leak down into the surrounding tissue. That is number one. Number two, that happens here due to the increased thickness of the blood vessel is, there will be, see, this is the blood vessel, okay, it has become thick. That means the lumen, the inner covering, whatever is there, it will become very narrow. Usually the blood vessel should be like this. Okay, it becomes because of the swelling or because of the thickness, whatever is there, the inner lumen will be this thin. Okay, so if it is this thin, whatever the blood has to flow inside, it will also decrease. Imagine a blood vessel this thick. If a blood vessel is this thick, there will be high amount of blood flowing through it. But if a blood vessel is this narrow, obviously the blood flow in it will also decrease. And also, one more thing that happens here is because of the narrowing, there will be increased resistance. Now, the blood is supposed to flow in a very proper area where the diameter is broad, but here we have constricted it too low and we're asking the blood to flow through it. Now, obviously, what happens? There will be a lot of restriction. Imagine I've asked you to pass through a door. You can easily pass through a door, but let's imagine that I've asked you to pass through a window which is very narrow. Then you'll have to put a lot of efforts, right? In the same way, the blood will also try to put a lot of effort because of the increased resistance. That's number two. Number three, and most important thing that happens because of the increased thickness is loss of elasticity. See, one classic feature that the blood vessels have is elasticity. Okay, so the blood vessels have this property of elasticity, wherein if you need increased blood flow, then the blood vessel expands. Okay, that's vasodilation. And when you need less blood flow in the blood vessel, then the blood vessel will constrict. It is vasoconstriction. It's a classic feature of the blood vessel. But because of this thickness, what happens? It will lose its property of elasticity. So there is no elasticity, there is increased permeability, there is blood flow reduction, there is also increase in resistance, and eventually it will lead to hypoxia and ischemia. There will be tissue hypoxia and ischemia. So all these characters together, whatever are there, they actually are making the blood vessel weak. Because of all this, the blood vessel is not becoming strong. It's not performing its activities properly. It's actually deteriorating in its performance. So hence, it is becoming thick. The blood vessel has become thick, led to all these, and it has finally become very weak. Okay. So in diabetes, the blood vessels become very thick and weak. Because of this, all this happened. Now you have understood. Now, let's talk about the kidneys and the diabetes. Okay. The kidneys, we have something called as glomeruli. Okay. These are nothing but the capillary network structure we have in the kidneys. Now, obviously, the glomeruli will also be affected because of the diabetes. When the glomeruli get affected, what happens? Whatever the proteins that are present in the glomeruli, they leak down because I told once the blood vessels become very thick, obviously there will be increased permeability because of which the structures within the vessel just drop down to the surrounding tissue. So as a result of which the proteins that are present in the glomeruli will leak down to surrounding tissue, and hence you will see proteinuria in the patient. I hope you all know what proteinuria is. Okay, this is one of the classic symptoms that you see in the patients of diabetes. A patient who has diabetes and he had started developing a kidney problem, the first thing that you see in the patient is the proteinuria. This is one thing, this is one way, or this is the actual way why you see proteinuria in the patients who have diabetes. And ultimately, if you can see, ultimately these kidneys are being affected because of diabetes. See, if this happens for a longer period of time, there is something called as glomerular sclerosis. That's a different pathology that occurs. It's not related to the case that we are talking about now, but I just want to know. There's one more condition also if this prolongs for a longer period of time. So yeah, keeping that aside, now we've understood how the diabetes is actually leading to a kidney injury. So now we have understood how a PTCA patient is prone to AKI if he already has a kidney disease, and you also now understood the link between the diabetes and the kidney. Already the patient who is having diabetes is suffering with kidney problem, and on top of that, you have given something which again affects your kidneys. Again, there is increased risk for AKI in this case. And the third thing that you have is the heart failure patients. How are the heart failure patients more prone for AKI? So basically what actually happens is in the heart failure patients, what is heart failure? First of all, heart failure is a condition where there will be increase, where the heart fails to do its function. Okay. Now what is the function of the heart? The heart has one function which is nothing but to supply blood all over the body. Okay, that's the heart's function. But the heart's function has failed. Okay, the heart is unable to do it. Then that's when you call a patient is having heart failure. In the heart failure patient, what actually happens is it's a different pathology. I'll just talk to the pathology later. But remember one thing: heart failure patient, there will be fluid overload and there will be shortness of breath. This is because see, after, let's just say there is already a heart failure patient, okay, a heart failure patient, you have given him PTCA, there are some clots, you have given him some PTCA. After giving PTCA, obviously what happens, the cardiac output should increase. Basically in heart failure patients, the cardiac output decreases, but you have performed PTCA, hence because of which the blood or the cardiac output shall increase. Now there is this sudden increase in the cardiac output. Initially, because of the dysfunction of the heart, the cardiac output has decreased, and because you have performed some surgery, suddenly the cardiac output has increased. It has not increased. It has reached this normal level, to be very honest, but then for the body, it is increased, right? So as the cardiac output increases, there will be some pressure differences in circulation. So because of this pressure differences, what actually happens, some fluids, whatever are present, these fluids, what they do, they will pass down into the surrounding tissue. Okay. Before passing down into the surrounding tissues, one thing that you have to keep in your mind is when a patient is having heart failure, okay, when a patient is having heart failure, when the cardiac output is decreasing, that means the systemic circulation also decreases, as a result of which the blood supply to the kidneys also decreases. Okay. When the blood supply to the kidneys decrease, there's a condition called as renal perfusion. Okay, there will be renal perfusion. In order to compensate this renal perfusion, see, the body will not sit calm when there is renal perfusion. Obviously, the body will try to act in order to prevent this renal perfusion, or in order to compensate whatever is happening in the body. It will try to compensate, but the compensatory mechanisms, whatever are there, they stress the heart furthermore, and they might lead to heart failure. Okay, that's one link between the kidneys and the heart failure. So, heart has failed to pump the blood, okay, the surroundings to systemic circulation, as a result of which there is renal perfusion in the kidneys, as a result of which there will be kidney problem. Okay, so you have seen three scenarios which are actually leading to AKI in patients. Okay, there are many more factors that actually lead to AKI. But in this case, if we talk about the patient that we are talking here, diabetes is one of the things that actually led to AKI post-operatively in this patient. Okay. And I just want to tell you one thing. Whenever we talk about complications, always remember complications are of two types. We have typical complications and atypical complications. Okay. Typical complications mean when there is a procedure done, or when there is a surgery done rather, or a treatment is given to a patient, something will obviously happen. Some complication will obviously happen. Then we say that it's a typical complication. And there are some complications that are very rare in occurrence. Okay, they're called as atypical complications. I'll give you an example for better understanding. Let's just take an example of fracture. There is a fracture patient. That patient is treated with external fixator. Now, one obvious complication this patient would have post-operatively is pain and pin site infection. Okay, this is a typical complication. Now, what is the atypical complication or rare complication? Atypical complications include in the fracture external fixator treatment would be your pin track osteomyelitis or the implant allergies. That would be your atypical complication. Okay, so here when we talk about AKI as a complication of PTCA, it is an atypical complication. Not every patient who is undergoing PTCA will have AKI. It's an atypical complication. It occurs rarely. Okay, it occurs rarely, and it's called. See, when a patient has undergone PTCA and is having a kidney problem, he got kidney problem, and we call it as contrast-induced nephropathy. Okay, this is rare, but it does happen. Okay, right. In our case, it happened. The worst case scenario has happened with the patient here, because the patient had a complication, or the patient already has the risk factor of diabetes that could have triggered AKI in this patient. Now, the next complication that we have in this patient is chest pain. Now, when I say chest pain is a post-operative complication, most of you might be confused, because just now the patient had a surgery in order to clear all these things. And the second complication, the post-operative complication in this patient is heart failure. Technically, we have treated this patient in order to prevent him from this chest pain and heart failure. Again, why is this patient getting this chest pain and heart failure? See, heart failure, I've already told you, one reason for the heart failure could be there is sudden increase in you have done PTCA, because of which the cardiac output has increased. Okay. Initially, the cardiac output was reduced, and now the cardiac output has increased. Now, because of this increased cardiac output, what actually happens is there will be some fluid released into the surrounding tissue, as a result of which you see edema. Okay, as a result of which you see edema, and when this fluid is accumulated in your respiratory system, you see shortness of breath. So that could be the reason why this patient is having heart failure symptoms, particularly shortness of breath and edema. Okay, that's one thing about the heart failure. Now, why is this patient actually getting chest pain? What's the point of getting chest pain? Now, the possibilities of chest pain in this patient could be because of revascularization injury. Now, what was this revascularization? Revascularization injury is during the PTCA procedure. I told you that a balloon is sent into the artery and we inflate the balloon in order to clear the obstruction, whatever is present. So while we are doing this, this balloon can actually cause irritation or injury to the arterial walls. Okay, that might lead to the chest pain. Okay, that is called as the revascularization injury. Now, one more thing that might lead here is restenosis. You have done the procedure, you have done the PTCA, but in some patients, what happens again, the artery will collapse or the artery will again go for stenosis. In this case, however, this might not be a chance because we have done stenting to the patient. Okay, the patient had stent, so collapse or restenosis is rare in this condition. Okay, or in this case. Okay, right. But the third situation because of which this patient might have chest pain would be myocardial injury. Now, what is this myocardial injury? When you're performing this procedure, there might be some, like injury to the myocardium or the heart muscles simply because of which this patient might be getting chest pain. So, keeping the restenosis aside, revascularization injury or the myocardial injury might actually lead to chest pain in this patient. Okay, now you have understood the case, you have understood the procedure, you have understood why these complications are seen in the patient, right? Clear? Now we'll go to the most interesting part, okay, which is the treatment of the patient. When we talk about treatment of the patient, we usually do not consider all these things. We do not consider the patient is having AKI, we do not consider the patient is having chest pain, the heart failure symptoms. Rather what we do is we directly ask the patient to do the cardiac rehabilitation, the basic routine of the cardiac rehabilitation, which is the aerobic exercises and the breathing exercise. In the breathing exercise, also one exercise that we definitely give them is spirometer and diaphragmatic breathing exercise. Of course, when you have heard about this case, I think most of you might also have thought about this. Again, I'm repeating the exercises: aerobic exercises, breathing exercises, which is the diaphragmatic breathing exercise, and the spirometer. Mind me not when I say this, if you thought that these three treatments are correct for this patient or these three treatments should be given for any patient who has undergone cardiac surgery, then you are wrong. At least you are wrong for this case. In this case, if you do this treatment, no, you'll kill the patient. Undoubtedly, you'll kill the patient. Why? Why can't we actually perform these exercises in the patient? Why can't we even perform spirometer in this patient and diaphragmatic breathing in this patient? Because one thing we know about diaphragmatic breathing exercise, it's a very calming exercise. So it can be given to any patient, right? That's what we think about diaphragmatic breathing exercise. So in order to be little safe, okay, even when I was in college, no, in order to be little safe, I used to give diaphragmatic breathing exercise to every patient because it doesn't have any like much contraindications or complications. It doesn't bring any complications, is what I used to think. But later when I did my PG, I realized that even the diaphragmatic breathing exercise is not very safe. Okay, but some breathing exercises which we do not actually prescribe the patient to do are actually very beneficial to the patient. Particularly in this situation, those breathing exercises comes very handy. Before talking in detail about the exercises, what we are supposed to do, let's discuss about the exercises which are not supposed to be done. Okay. Number one, you're not supposed to do any high intensity exercises. No high intensity exercise in this case. When I say no high intensity exercise, most of the students might be thinking that it's okay. I'll not give any high intensity exercise continuously. Rather, what I'll do is I'll give certain intervals. Okay, I'll give some intervals and I'll do this interval high intensity exercise. Is what some people might be thinking, but no, even that is contraindicated. See, in this case, the patient, whatever we are talking about, he has heart failure symptoms as well as he has chest pain. So in this case, you cannot give high intensity exercise. Let it be with interval or without interval because it will eventually increase the chest pain and discomfort to the patient. Okay, so high intensity exercises with interval or without interval are totally contraindicated. Now, the next thing is, now you people might be thinking that, okay, high intensity exercises are not indicated, they're totally contraindicated. I understand. One thing I'll do, I'll just go for walking, because walking, bedside walking, we give to every cardiac rehabilitation patient. Every patient that comes to us for cardiac rehabilitation, we suggest them to go for some walk. Okay, at least the bedside walk. So you might be thinking that I prescribe walking. No, again, walking, you cannot give walking in this case, because again, walking will trigger your chest pain. Okay, walking is also stillness. Okay, so remember one thing. Remember one thing. A patient is complaining you with chest pain, discomfort, then no to any vigorous exercise. Only simple exercise should be given to this patient. So you cannot even give walking. No high intensity exercises, no walking. Okay, remember. Then next thing, you might be thinking that okay, one most common exercise in the cardiac rehabilitation is resisted exercises. Now you people might be thinking that, okay, you told no exercises, no like aerobic exercises, and or simply no high intensity exercise or no walking, then go for resisted exercise, because resisted exercises are also a part of the cardiac rehabilitation, right? So you people might be thinking that go for resisted exercise. No, again, resisted exercises are also contraindicated. You cannot give resisted exercises because, see, I tell you why resisted exercises are complicated. These resisted exercises or the isometric exercise, whatever you're thinking of, instead of giving physical pressure on the patient's body or giving weights to the patient's body, I'll start the patient to do isometric exercise, is what you people might be thinking. But even the isometric exercises are also complicated because they increase stress on your heart. Okay, I hope you're understanding. See, these are the quite basic exercises. When we talk about cardiac rehabilitation, no, these are the exercises that comes into our mind. The resisted exercises, the isometric exercises, the walking, all this comes into our mind, but these are contraindicated totally in this patient. And in the same way, one more thing, always remember, whenever there is a cardiac surgery case, one thing you have to remember is, I've seen many patients, like many therapists in the ward, they ask the patient to go for range of motion exercise, which is good. Going for range of motion exercise is good post surgically, but overhead activities cannot be done in this case. Okay, so whenever you're giving range of motion exercise, in this case you can give, but not overhead activities, because here in this case the patient is showing symptoms of heart failure. When the patient is showing symptoms of heart failure, when you're suspecting heart failure, if you ask the patient to do overhead activities, remember one thing, the further the the target organ or the target tissue from the heart has to suffer more or stress more in order to pump blood to the organ or the tissue. So if you're asking the patient to do an exercise wherein he has to lift his arm completely up, okay, now the heart has to work more in order to supply blood up. Okay, so no overhead activities. Remember that. Keep it in your mind. If a patient is coming to you with heart failure, no overhead activities. Okay, so no overhead activities, no resisted exercises, no walking, no high intensity exercise, and now comes a very favorite exercise, which is diaphragmatic breathing exercise. Now you people might be thinking that, okay, all the exercises that I've known in cardiac rehabilitation, you have told that they are contraindicated. I'll go for my very favorite diaphragmatic breathing exercise, is what you people might be thinking, but again, it's very complicated in this case. Not just the diaphragmatic breathing exercise, even the spirometry is complicated in this case. Okay, I know you people might be shocked at this point. You people might be thinking that what rubbish is she even talking? But I'm talking fact. Remember one thing: diaphragmatic breathing exercise is not suitable for every cardiac condition. Okay, diaphragmatic breathing exercise is simple exercise for a healthy patient, not for a patient who has undergone a surgery. So in this case, the patient is already having chest pain. The patient is having discomfort. Now, if you ask the patient to go for deeper breaths, there will be obvious increase in the chest pain, and there will be increase in discomfort to the patient. The same implies for this incentive spirometer. If you ask the patient to perform incentive spirometer with chest pain and discomfort, it will trigger more, or it will increase the chest pain and the discomfort. So these two are totally contraindicated. Okay. Now the routine rehabilitation is completely contraindicated in this case. Now what treatment should be given in this case? Starting with the exercises of breathing. In the breathing exercises, one exercise that we can give in this patient is pursed lip breathing. Now, pursed lip breathing is very, very effective exercise in this case. So initially, in order to treat the patient, you can go for pursed lip breathing. Okay. This is because it is simple, it is soothing, and it also relieves. Okay, it relieves the chest pain and it gives like it directly doesn't relieve your chest pain. It just makes the patient feel comfortable. So hence the discomfort, whatever is there, that can be reduced. Okay. I just turn off my screen. I think that's quite deviating. Yeah. Right. So yeah, we are talking about the pursed lip breathing. So when we are talking about the pursed lip breathing, the pursed lip breathing is very like calm and it's very soothing. So the patient will feel relieved. Okay, the discomfort, whatever the patient is having, will be relieved. Hence, he'll be very happy and he can very comfortably perform the pursed lip breathing. Once the chest pain or the ambient or whatever is there in the patient has resolved or come into control, then you can actually advance the patient into diaphragmatic breathing. Okay. See, again, I'm telling you, diaphragmatic breathing exercise is not meant for every cardiac patient or every post-operative cardiac surgery. See, for example, let's just take the example of CABG. Leave about PTCA for some time. Let's just take the example of CABG. For those who don't know what CABG is bypass surgery. Simpler terms, okay, layman language. Bypass surgery. So in this case, what actually happens, there will be a thoracotomy done. And there will be a large incision, okay, in your sternal area. Now, with this large incision, if you are asking the patient to go for a diaphragmatic breathing exercise, wherein the chest has to expand completely, the patient will not cooperate. He will have immense pain. Okay, so every time diaphragmatic breathing exercise is not the solution. Remember that. Okay, so in this case, in our present case, you go for pursed lip breathing first, and once the chest pain is under control, then you can go for the diaphragmatic breathing, like you advance into the diaphragmatic breathing. That's number one about your breathing exercise. In the same way, once the chest pain has come into control, then the discomfort has come into control, then you can also advance into the incentives parameter. Don't immediately give incentives parameter to the patient. Okay. Patient is already having chest pain, so keep that in mind. Now, the next exercise that we can do is walking. What ma'am is actually telling is what you people might be thinking. I just told her walking is contraindicated. Again, I'm telling that you have to give walking to the patient. See, walking is one exercise which is really, really important, but however, in this case, walking cannot be done. So what we'll do is we'll be very clever at this point, okay? We'll break down the activities that happen in walking and we give them as separate exercises. I hope I'm making some sense, okay? So for you to better understand, I'll tell you what happens. Basically, now we cannot ask the patient to get up and walk. So what you will do, you will make the patient sit on the couch, or maybe you will ask the patient to sit on a chair, and then you will ask them to do seated marches. Seated marches are really, really like good. Okay, so the same activity, whatever the patient does while walking with his lower limbs, will be done with sitting position. Here the patient is not moving so much. Here all your, see, while you're walking, all your muscles from your upper limb, your lower limb, everything has to become activated, right? Because all of them move. But here, the upper extremity, the chest, everything, the thorax, everything is intact, stable. But the only, we are just training the lower limbs. Okay. However, even the seated exercises or the seated marches, whatever are there, should be given at a very low intensity, which is you just have to reduce the period of time how much you're giving for treatment. Okay. In generally, if you give seated marches to a patient for say some 15 minutes, in this patient you can only give it for 5 to 7 minutes because he has chest pain and heart failure symptoms. So you cannot give it for a prolonged period of time. Okay, that's number one. Okay. Now, number two, you cannot, the next statement that you can give here is now your lower limbs are sorted. Now, coming to your upper limbs, what you do is you ask the patient to do arm circles. Now, what are these arm circles? Okay. Arm circles is you will have to ask the patient to move his shoulder roundedly in a round, in circular motion. You have to ask the patient to move his shoulder. Now, in this case, how you try ask the patient to do is you ask the patient to fold their elbow something like this. Okay, I hope you can see my elbow. You ask the patient to fold the elbow, ask the patient to put his palm on the shoulder, and then ask the patient to turn the shoulder like this. Okay, and remember, no overhead activity. You cannot ask the patient, whatever exercise you're giving, you cannot ask the patient to do it overheadedly. This also, instead of doing it in a long lever, if you do it in a short lever, that will be more easy for the heart to pump blood. Okay, so instead you choose a short lever instead of long lever. Okay, that's number two. You go for your arm circles, and then also you go for the wrist circles. Okay, you ask the patient to go for the wrist circle. So if you can decode it properly, if you are just observing it properly, all these motions happen when we are walking. So our shoulders move, our wrist moves when we walk. Okay, our legs move when we walk. But because here we are unable to ask the patient to walk, what we have done, we have cleverly broken down the walking activities into different exercises, and we have given the patient to do all the exercise with a reduced period of time. Like you're asking the patient to do seated marches for 5 minutes, the arm circles for 5 minutes, and the wrist circles for 5 minutes. Now, the range of motion is achieved, okay, in your upper limbs and your lower limbs, sorted, okay. Now, the other technique what you have to do in this case is relaxation. Relaxation is really important in this case because again, see, the patient is having a lot of discomfort. So if you ask the patient to do something like progressive muscle relaxation, then that could bring a great comfort to the patient. Okay, once the patient is comfortable, no, you can actually give a good exercise to the patient. Now these exercises, whatever I'm talking about, these are for the initial stages until the patient is showing the signs of discomfort and angina. Now, once the angina and discomfort has come into control, you can go for one beautiful exercise. Okay. Now, this beautiful exercise, before I talk about that beautiful exercise, most of them think that that exercise can be only be used during stroke, and in cardiac rehabilitation, this exercise has no role, is what many students think. But this exercise has role in every department. If you properly utilize it, it can be used in every department. Okay. Now, before naming the exercise, I would like to tell you the benefits this exercise actually gives us. It actually helps us in giving increased range of motion. It helps in improving flexibility. It helps in increasing circulation. It promotes relaxation as well. Okay, so there is increased range of motion, flexibility, increased circulation, and it's also promoting relaxation. Now, what is this exercise? This exercise is your PNF. Okay, PNF. Now, you might be thinking that I have already told you that no resisted exercises, but in PNF, we have to give some resistance. Now, am I contradicting my statement? No, I'm not contradicting my statement. I'm stuck to my statement. See, you can go for isometric exercises once the control or once the situation is under control. Okay, once the situation is under control, you can go for the isometric or the resisted exercises. But the isometric and the resisted exercises, they can give you only a little benefit. But if you go for PNF, it gives you all these benefits. Okay. See, again, there's no need of separately going for ROM exercise or flexibility exercise. Post PTCA, you also give the patient some flexibility exercise as well. Okay. So instead of giving separate exercises, you can choose one exercise which gives all the benefits, which is nothing but the PNF. Okay. Yeah, because I'm talking about the resisted exercises, I just want to add one point over here. See, in our patient, we told that, like I've told that the patient has this complication of AKI. And one treatment method for AKI is hemodialysis. Okay. Now, while performing the hemodialysis, like before performing the hemodialysis, there is this minor surgery which is called as fistula. We make a AV fistula, which is nothing but arteriovenous fistula. Now, if the patient, like in our case, we don't know if the patient is having this fistula or not, but if this patient is having fistula, then the resisted exercises to the fistula hand are contraindicated. Now, what is this fistula? Why are the resisted exercises complicated? Fistula, as I've told, it is arteriovenous fistula. It's called as AV fistula. So what we do is we join one artery and we vein together, because in hemodialysis, what happens? We take out the blood from the body, purify it, send it back. It's not like we are taking the entire blood, purifying it, sending it inside. It's a cyclic process. The blood will be coming out, purifying, going in. It's a circular process. Okay. So by doing this, we need a source from which there will be like a high amount of blood can be drawn out. Okay. So in order to do that, we perform this AV fistula to the patient. Okay. So it is usually done in the elbow area, in the cubital area. This is done. Okay. So as part of this AV fistula, okay, one precaution that has to be taken is the patient, this is usually done for the non-dominant hand, okay. So we ask the patient, whoever is having AV fistula, he will be warned not to lift heavy weights, because it is a man-made thing. Fistula is a man-made thing. AV fistula is a man-made thing, and anything which is man-made cannot withstand for a longer period of time. So if you just lift weights or lift heavy weights, or if you give some resisted exercises, isometric exercise, high chances the fistula might blast and it might lead to your internal bleeding. So again, If this patient with AKI, we have the post-surgical complication as AKI, if he is subjected to hemodialysis and if he is having a fistula, obviously, if he is subjected to hemodialysis, he will have a fistula. So, if he is having a fistula, you can do resisted exercises after the resolving of the chest pain and discomfort, but you cannot do the resisted exercises to the fistula. I hope you're getting my point. Once the chest pain has got under control, you can go for resisted exercises or the PNF, whatever I'm talking about, or the isometric exercises. But to the fistula hand, you cannot give that, because if you give it, the fistula will break and it will be a huge mess. Okay, right? Yeah, I'm talking about PNF exercise, right? So once all these things comes under, control, you can go for PNF. Now, in PNF, we have so many exercises, right? PNF has so many types of exercises. Now, what exercise can we give from PNF in this case? You can actually give hold relax, you can give contract relax, you can give rhythmic stabilization to this patient only when the chest pain and discomfort have been completely eliminated and the patient is totally free. And this PNF is a step of progression. Okay. Initially, you do all the exercises that I've told, the pursed lip breathing and everything. Once the patient has shown some prognosis, you can gradually increase the set of exercises with the help of diaphragmatic breathing exercise, pyrometer, and PNF. So that is something about the what rare treatment protocols coming into action and some common treatment protocols being contraindicated. I really hope you enjoyed knowing about this case, and I really think this case study has been little informative to you. If you really enjoy some content like this, then I recommend you people to join Prakara or just to subscribe Prakara. So that's the end of our session. Thank you.